Hello and thanks for watching this talk about the Suspicion of Sepsis dashboard, where we'll be particularly looking at the data for trusts in the North East and North Cumbria. My name is Tony Roberts. I'm Deputy Director for Clinical Effectiveness at South Tees, the acute hospital provider based in Middlesbrough. I also work for the North East Quality Observatory Service, supporting trusts in our region to monitor and learn from deaths in hospitals. I'm the Patient Safety Lead for the Academic Health Science Network in the North East and North Cumbria, where we're working on clinical topics like deterioration and sepsis, which is how I'm involved in the work on suspicion of sepsis. With my NECOS hat on, I've been involved in work across the region over the last 5 years on infection, originally collecting data across a set of clinical measures for pneumonia and sepsis. More recently, the National Patient Safety Measurement Unit, working with Imperial College Health Partners, has produced the dashboard we're going to look at, providing data about the impact of infection in hospitals. The National Suspicion of Sepsis tool is publicly available at this web address. It allows trusts and other organisations to see how they perform across a range of metrics relating to sepsis and infection, based on a paper published by Matt and Ada Kim, who grouped diagnosis codes for infection so we can find those hospital admissions from which sepsis can arise. Hence he coined the term suspicion of sepsis. NECOS have taken an extract of this data to produce comparative analysis for the 9 acute trusts within the North East and North Cumbria. Each of the slides I'm going to show you display charts grouping the North East and North Cumbria trusts into 3 areas. South of Tyne, that's SOT, on the left, north of Tyne, NOT in the middle, and Durham, Darlington and Tees, that's DDT on the right. The charts present monthly data from April 2015 to March 2018. The first row of charts show you the number of emergency admissions for each trust. They are represented by the higher lines with markers for each point. The lower lines, without markers, are the number of emergency admissions we can attribute to infections from which sepsis might arise. The black lines are the England averages, which are shown for comparison. The charts are small because we want to look at the general pattern without getting too distracted by individual points. I'll give you a moment to look at the first row of 3 charts. We'll be looking again at this pattern again on the next slide when we consider the proportion of spells which involve suspicion of sepsis. Okay, let's move on to the second row of charts on this slide. These show the trend in emergency admissions coded to sepsis. That is, admissions containing A40 or A41 diagnosis codes. Again, the black line is the England average, which shows a clear shift in the data in 2017-18. This coincides with the change in coding rules for sepsis that was introduced in April 2017. We can see variation in when this change in coding practice occurred in the trusts in the North East and North Cumbria. So for example, in the middle chart we can see the orange line had higher levels of A40-41 early. This is Northumbria, who were working on sepsis from before April 2015. In the chart on the right, we can see that the shift took place in 2016-17 for 2 trusts, which are North Tees and South Tees. Most trusts became similar to England after the change in coding rules in April 2017. On the previous slide, the data showed the volume, that is the number, of admissions. Charts on this slide on the top row show the proportion of emergency admissions which are for suspicion of sepsis. The proportion for England tends to be around 40%, with clear winter peaks shown in the data. There's some evidence that rates may be rising over the 3 years, and it clearly shows what an important source of emergency admission infection is for the NHS. The second row of charts shows the average length of stay for suspicion of sepsis at around 10 days for England, and this shows a fall across the region consistent with the national trend. We now move on from looking at the trend in length of stay to looking at the pattern for suspicion of sepsis in terms of emergency bed days. Slightly more than half of all the emergency bed days across the region relate to suspicion of sepsis, and again you can see evidence of a winter peak. Suspicion of sepsis emergencies account for more than half of the bed days, from around 40% of admissions, so they have longer lengths of stay than other diagnoses. So these patients are really important in terms of resource use. The second row of charts show the suspicion of sepsis for intensive care emergency bed days as a proportion of all ICU bed days, based on the number of critical care beds we know exist in the region, multiplied by the number of days in the month, and assuming an 82.5% occupancy rate. This gives us a rough feel for the high proportion of critical care resource needed for patients with infections at more than half of emergency bed days accounted for by this group. The national line, the black, is fairly stable, but for individual trusts there is a lot of variation. The final set of 6 charts show readmissions and the mortality rate for suspicion of sepsis. So we're now looking at the outcome for patients' hospital stay. The picture for readmissions is that across the region it's slightly above the England rate, hovering just below 20%. So nearly a fifth of patients are readmitted within 30 days. The second row of charts shows the variation in mortality, with 2 clear winter peaks visible in the data for England. You have to be careful how you interpret the data for mortality, as some trusts provide rehabilitation, community or hospice services, while others do not. So trusts are not directly comparable, although the pattern through time for each trust is useful and is fairly consistent for the trusts in our region. I'd really encourage you to go and have a look at the dashboard for yourself. There's lots of supporting material alongside it, and you don't want to think about this in isolation. It's part of a wider picture. The website provides you with lots of supporting narrative and further materials. Many thanks for listening, and please contact me directly if you'd like to discuss this further. My thanks to Michael Walkley at NEQOS for making the charts, and to Imperial Health Partners for the extract of the data.